Hispanic Council on Aging's Capitol Hill briefing. My name is Jeff Cruz, and I'm the Executive Director of the Latinos for Secure Retirement Coalition, and it is my honor to moderate today's event and be with you guys for this briefing. National Hispanic Council on Aging's Capitol Hill briefing is an important event designed to educate lawmakers on key issues impacting Latinos so that we can facilitate solutions on these issues at the policy level. Today, we have an amazing group of experts sitting here to discuss important topics such as anti-obesity medications, liver disease and MASH, mental health, 340Bs, and Medicare Advantage. Also, we want to highlight that this event includes findings from the NHCOA's 2025 Status of Hispanic Older Adults Report, or SHOAR, a data and testimonial-driven report that offers policy recommendations to address the challenges currently faced by Hispanic and Latino American older adults, their families, and their caregivers. Please stay tuned. You can go to the website, www.nhcoa.org, and their social media platforms. They're on Twitter, Facebook, Instagram, all the social media platforms for more information. And we also want to thank our generous sponsors, AHIP, AstraZeneca, Bristol Myers Squibb, and Novo Nordisk. We would like to recognize, finally, National Hispanic Council on Aging's president and CEO, as well as the rest of the staff who did an amazing job in organizing and planning this event. And also for folks coming in, if you need translation or if you need any assistance, just let us know and we'll get that for you. Now, to begin this event today, it is my honor and pleasure to introduce Dr. Yanira Cruz, the President and CEO of the National Hispanic Council on Aging and one of our nation's foremost advocates and spokespersons for older adults. Welcome, Dr. Cruz.
Thank you, Jeff, for being here and helping us moderate this very important session today. And buenos dias. Good morning, everyone. It's great to be here, and thank you to all of you older adults, the persons from Vida Senior Center who are here, from Casa Iris. Muchas gracias por su participación. Sean bienvenidos. And thank you to the speakers for your time and talent this morning. And for over 50 years, NHCOA has worked to ensure that Latino older adults, one of the fastest growing aging population in our nation, are seen, are heard, and fully represented in federal policy. Today's event reinforces that commitment. This briefing is especially important because it's also the release of the report, the Status of Hispanic Older Adults report. Each year, this report provides a detailed overview of the social, the economic, and public health issues impacting Latino older adults. And this year's report emphasizes one key point. Latino older adults still face significant barriers to adequate health care. These barriers are propped up by systematically deficient policies and healthcare systems that do not properly address the needs of a population that now makes up 1/5 of the entire US population. That being said, it is effective and comprehensive measures of policy that can eliminate these barriers. I'd like to share this morning some important and key findings of this report. First, Latino older adults continue to experience a higher burden of chronic disease, including elevated rates of obesity, diabetes, and liver disease. These conditions are influenced by social and structural factors that limit access to preventive care and early detection. The report also reveals ongoing concerns about medication access and safety. These includes misuse within the 340B program and the increasing threat of counterfeit medications in the area of anti-obesity medications targeting vulnerable communities. The report also emphasizes significant gaps in mental health support, driven by stigma, driven by limited bilingual services, and a shortage of culturally competent providers, which contribute to late diagnosis and inadequate treatment among older adults. And despite this, the report also reflects the resilience and strength of our community. Every day, caregivers, promotores de salud, researchers, and local organizations across the country are working to break down barriers, impact research, improve awareness of health and wellness, and connect older adults to the services they to live comfortably and age in dignity. Today, our goal is simple. We want to ensure that the lived experiences of Latino older adults inform the policies designed to support them. We are here to elevate their voices, share what we have learned, and collaborate over solutions that strengthen access, that strengthen research, prevention, and equity. Thank you for being part of this important conversation. Only together can we transform insight into action and ensure that every older adult has the opportunity to age with dignity, to age with good health and security. Muchísimas gracias. Thank you.
Thank you, Dr. Cruz. Let's give her another big hand. Now, when we advocate for older Latinos, we are lucky that there's a coalition of the Hill called the Congressional Hispanic Caucus, which is most of the Latino Democratic members, and they're just very important allies as we fight for policies that will help older Latinos. And we are lucky today to be joined by the chair of the Congressional Hispanic Caucus, Congressman Adriano Espia. Yeah,
Buenos días. Thank you. Thank you so much for being here. Gracias a la doctora Yanira Cruz. Thank you for your leadership, your advocacy, to all of you for your leadership and your advocacy for adults. We always needed an adult in the room. Nosotros siempre necesitamos a un adulto en el salón. It is always mind-boggling to me. How is it that we don't take greater awareness and we support the opinion of adults that have been there for us, that have opened the doors for us, that have given us the wisdom to understand the path through which we must move forward. I'm mind boggled very often by the fact that we gotta save ourselves from us because we don't pay the attention that we should to the opinion of all those adults. Yo creo que nosotros muchas veces no le ponemos atención a la opinión de los adultos, que son los que abrieron el camino, los que nos dieron la sabiduría y los que se esforzaron para que todos nosotros estemos aquí hoy. Y muchas veces ignoramos y no valoramos la opinión de ustedes. De manera que yo espero de que su visita aquí hoy, I hope that your visit here today is one that we listen to your opinions, que vamos a escuchar sus opiniones. Y como presidente, as chair of the Congressional Hispanic Caucus, 43 members, including 4 U.S. senators. We're here to listen to you. Estamos aquí para escuchar. Escuchar es muy diferente que oír. Uno oye a un camión de bombero o de policía cuando viene con la sirena, pero uno escucha a un ser humano. Hay una gran diferencia entre escuchar y oír. Y estamos aquí para escuchar. I'm proud to represent the 13th Congressional District, home to one of the largest and most diverse Latino communities in the country, with rapidly growing older adult population that continues to depend on basic benefits from Washington. Las poblaciones de nosotros continúan dependiendo de servicios y beneficios básicos para nuestro bienestar, como es el Medicare, como es el programa de SNAP, de cupones de alimentos. Esos son servicios básicos que nuestra comunidad, particularmente las poblaciones de adultos, necesitan diariamente. So we must be laser focused in making sure that we protect that. Tenemos que proteger eso y estar enfocado en la protección de esos servicios básicos. Yo quiero darle la gracia a esta organización por estar aquí con nosotros hoy. I want to thank the National Hispanic Council of Aging for being here today to advocate for you on your behalf and to bring you here today. Y vamos a trabajar de mano en mano. We will work hand in hand to move your agenda ahead, para adelantar su agenda hacia adelante, principalmente escuchando sus necesidades. Así que gracias de nuevo a la doctora Yanira Cruz, a todos ustedes. Thank you all for being here. And never forget that we are here because of them. Nosotros estamos aquí por ustedes, no por otra cosa. Yo sé que la juventud es muy inteligente, tienen grandes destrezas, they have great tools, young people, they're in many ways they're better than us. En muchos casos son mejores que nosotros porque tienen la revolución tecnológica en sus manos y nosotros no la tuvimos. Pero ellos están aquí por ustedes. Y las oportunidades que ellos tienen es por ustedes. Y sería un grave error no escucharle a ustedes y avanzar la agenda que nos une a todos nosotros. Thank you so much and keep the faith. Thank you.
All right, thank you. Now we are going to get today's panel underway. So obesity remains a serious health challenge in our community, even more so in Latino communities than in other communities. So as demand for new weight loss medication has grown, we've seen counterfeit and unapproved products that are becoming more common and really causing harm and damage to our communities. So these fake medications worsen barriers to care and put our communities at risk. And so we're going to hear a little bit more about this from our first speaker, Dr. Ray Serrano, who is the Director of Research and Policy at the League of United Latin American Citizens, or LULAC, which is the nation's oldest and one of the largest civil rights organizations. So welcome, Dr. Serrano.
Thank you. It's hard to go after Congressman Espaillat. Voy a hacer mi presentación en Spanglish. I'll try to do Spanglish. Try to copy Congressman Espaillat here. First, let's see how we do this. There we go. Okay. All right. When Dr. Cruz asked me to talk about this topic here, I wanted to talk about the idea of medications and how we get them. And we know that medications are very expensive. We know that you get a prescription for a certain, for something, and you go to the Walgreens or CVS, and they say you have insurance, you have your little GoodRx card, and it says it's $75. Imagine if you had a medication that was $300, $1,000. And imagine a medication that you badly need for obesity to get to a certain weight, and it's $1,300 a month. And so, what I wanted to talk about this perfect storm, this idea of what we're seeing here for Latinos, we're seeing basically three forces that are happening that are putting Latinos in the worst situation when it comes to drugs, especially drugs for anti-obesity medications. So, it's the word. Let's do next slide. I need to tell you next slide. So, force number one. The problem of obesity for Latino communities is growing. It's bad. It is getting worse. Of the adults, of Latino adults that we have, nearly half of the Latino adults are obese. Not overweight, obese. If you include overweight and obesity, it's about 87%. Of children, it is mostly Latina women, right? So if you see, there's a higher percentage of Latina women, adults, than Latino men who are obese. If you look at children under 18, it's Latino boys. Then, so basically, what we're seeing right now, as over the next 5 years, we're going to see over 50% of our population will be obese. Again, not overweight, obese. When you see that compared to other groups, it's us and African Americans. But even overall, it's high. For over the whole country, it's 42%. So it's still much higher than the rest of the country, but still, it's getting worse. Next slide. Let's do that way. When you think of reasons why obesity exists, there's a lot of reasons. There's genetics, there's the built environment, there's the food environment that people have. I wanted to point out some stats here, like something that just shocked me. When you think of like 13% of the United States population, about 39.5 million people live in an area where there's no grocery store. That's particularly for Latinos. Like, if you don't have a car, or you don't have somebody to drive you to the grocery store, you want to go to the nearest grocery store, and there isn't one. They close down. So then, what you do see, so they call that a food desert. But in the contrast of the food desert, you have the fast food swamps. So you see the areas. You see predominantly Latino areas or African American areas, and you see the Burger Kings, the McDonald's, the Taco Bells, and you see from that, of the percentage, 42.6% of African Americans, 35.5% of Latinos eat fast food on a daily basis. On a daily basis. I had a hard time believing this, but I started thinking about asking people. I was like, well, they say, well, before I go to work in construction, nos paramos en McDonald's. Llegamos a McDonald's, agarro mi café, y agarro the chicken nuggets and this, and it's a daily routine. People go to McDonald's or they go to fast food on a daily basis. And it's not surprising that this is the case. Again, like calories that are not nutritious, they're basically adding to the weight of people. When you think of food stamps, when you think of like a percentage of Latinos and African Americans who are on food stamps, in the debate where they talked about food stamps and food shortages, I just wanted to point out like something that most people don't think about. How much is it really? And I wanted to calculate this for DC. You're talking about less than $2 a meal. So in DC, a person on food stamps is $6 a day, $6.16 a day. In Maryland, the same thing, and then in Virginia, it's even lower. It's less than $2 a meal. So if you're thinking about like buying healthy fruits and vegetables and so forth, think about $6 a day. If I were to go down the road from where I work, like the Subway, the cheapest thing on the menu is a tuna sandwich at Subway, and that's $6.75. And if I can't even use food stamps to buy that, but if I could buy that, that would be my only meal I could have for the whole day, a 6-inch sandwich. So again, obesity, high prevalence, high incidence of obesity, high new cases of people becoming obese, a large percentage of our population that is obese. That's force number one. Next slide. So then you have this thing called compounding. So compounding, think of a compounding is like, so pharmacists are trained to do this. Like a pharmacist will say, I take this medication, it makes me throw up. Can you give me this other thing? They're like, okay, we're gonna mix it with this. Uh, this medication is too strong for me. Can you break it apart? Okay, we're gonna make it so it won't be too strong for you. Okay. That's the traditional sense of compound. What we're seeing now is compounding that is done not by the pharmacist, but somebody in another state that is done online, and they say, we're going to put a B12 shot, B12 added to this, and this is going to be better for you because it's going to allow you to lose weight and get energy. And you're going to order it online, and then you're going to get that medication. But that doctor, that person that prescribed it, doesn't know you. They don't know. They haven't done the blood work. They haven't seen you. So again, what we're seeing is getting worse and worse. So next slide. So I'm going to go back to the medications of what we saw for obesity drugs. In 2022, there was a shortage of obesity drugs. People wanted Ozempic. People wanted Mounjaro. But there was a shortage of it. So a lot of the pharmacists said, okay, we're going to microdose. We're going to give you a smaller amount, so we're going to give you it that way. But then there was these new marketplaces that came up and said, we can sell you Ozempic. We can sell it to you, just go online. And you go online and we'll give it to you with a B12 shot. We'll give you B12 and Ozempic, or we'll give you this vitamin, or we'll give you this, and that'll be good. But the problem was it wasn't FDA approved. And these people were just doing this in another state. They were not regulated. They didn't really know you. They would do it by telehealth, and they would prescribe it to you, and in large amounts, and they were making a lot of money because they were saying they were doing it because of the shortage. So now we're seeing that that's the problem. So that's the landscape. So again, what happened? The risk of compounding, it just exploded. The market started exploding. Fake weight loss drugs nearly killed me. E-sellers of compounded weight loss drugs are going higher and higher. Nearly half of online pharmacies are selling weight loss drugs and are operating illegally. You're seeing these drugs getting on the market more and more and more, and the challenge is, how do we pull it back? Next slide. Again, patient safety is a big risk here. You see, for GLP-1s for weight loss drugs, it's not like a pill that you can just like, when you take it, you're like, oh, I feel sick, let me throw it up. It's an injection. It gets in the system. Once it's in the system, it's there. You can't unless you can, like, I guess like a vampire, take it out, but you can't take it out of your system. So it's there. So the problem, again, you're seeing this becoming more and more. Next slide. So what I call the Wild West in a syringe. So you have, again, a big challenge right here. You have the FDA, the DEA, the Drug Enforcement Agency. These two agencies that were supposed to be regulating this stuff are pushing deregulation. They're saying, no, we want the states to do it. We want the industry to do it. But the industry is not checking itself. And so the dosing errors differ. So somebody starts on this drug and they found it online. They started taking Ozempic online. And now they actually want to go to a doctor and take real Ozempic. Well, they don't know where you started out, because the dosing that they have you on the online version is not the one that they're giving you in the actual the regular one. The sterility failures, again, you're talking about injecting something. Like we've seen in other cases where we saw with meningitis vaccines, they had fungus in the vials, fungus in these vials. And then unapproved altered formulations of GLP-1. So again, it's getting worse and worse. So that's the second part, compounding. Force 3, counterfeits. So if there was compounding, and that's kind of legal because it's kind of made up drugs. Kind of, you think of a bootleg drug, and then there's flat out counterfeit. Counterfeit. I use this photo here. My sister's an OBGYN in El Paso, and she talks about in El Paso. You do the U-turn. You go down to Juarez, and they have literally the billboards before you even get to Juarez. Farmacias similares, lo mismo, pero más barato. Like the same but cheaper. And they sell them, and people will go. They get charter buses. They go down to buy their drugs because they need the drugs, right? But the problem is that these drugs are not real drugs, and a lot of times they're fake drugs. They might be either compounded drugs, if they're good, or they're flat out just counterfeit drugs. Next slide. And it's not just in El Paso. It is not just in Mexico. It is not just in Latin America. I wanted to show you these two things. On the left is the actual Wegovy website. This is the company website, right on the left. Lose weight, keep it off. This is Wegovy. That's the real drug. On the right is the fake drug. You see how similar they look? Almost the same people. It's Wegovy Canada, but it is entirely, there's real drug on the left, the fake drug on the right. How do you know the difference? Next. Again, a big challenge, right? See, what we're seeing is targeting Latinos and women of color. So we're seeing these ads like Farmacia here, free delivery. Se habla inglés, we speak Spanish, se habla español, English spoken. You get diet pills, painkillers, travel medicine, all of these med spas. So we're seeing increasingly people going to med spas. They're not going to the doctor now. They're going to these kind of, I don't know how you call them, just medical spas. Like you go. People think that there's a doctor working in that medical spa. It's owned by a doctor. The doctor might be in another state, and it's somebody who's prescribing the medications there. That they have no regulation. Again, these are the Ozempic and Mounjaro. These are very serious drugs to be taking. They're injected, so you can't take them out, and they're very strong. They can really mess up your stomach. They can really mess up your system if you take the wrong one. So, what we're seeing again, a deliberate targeting to Latinos. Here's the scary thing that I found. In terms of people buying medications online, nearly half of people in the U.S. have bought drugs online. Nearly half. So, which means that people are going online, they're, you know what, I'm going to order this pill online, I'm going to order this online, and quite often they don't know what they're getting. They think, like again, you saw the difference between the Wegovy, the actual real Wegovy, and the fake Wegovy. You see how similar they are. Yeah. Next slide. And you see, I just want to show you the difference between the authentic and the counterfeit. They look exactly the same. Pfizer, Viagra, you can see it's almost exactly the same. There's a real one and the fake one. How can you tell the difference? This one right here, what you're seeing of these drugs right here, they are research use only. These are supposed to be used on lab animals or APIs, and there people are ordering them online. These pharmacies are ordering online. In this case, they were ordering them. They were mixing them in a closet. They were mixing it in a closet and selling it to people online as if it was a real pharmacy, but it was really ordered from for research use only, from a Chinese kind of pharmaceutical or chemical company, bringing them in, mixing them in a closet, and then selling them on the market. So next. And then the last point of this, why Latinos are uniquely situated. Next. Again, lack of oversight. What we're looking at. The next one. Next one again. Why I think Latinos are uniquely situated on this is one, Latinos tend to get their news from WhatsApp, Facebook, and YouTube. That is the number one. YouTube is one of the biggest sources of information for Latinos. The platform, this is from my studies from Naleo that we've seen that YouTube and Facebook. Now, a couple things that happened in 2022 and in 2020, we saw if I said COVID vaccine gives you cancer, it was flagged as misinformation. But if I say la vacuna de COVID te puede dar cáncer, the same thing in Spanish, 85% of the time it will go through. And the reason for it, we found out from the Meta leaks, is that 87% of the misinformation budget for Facebook, was only focused on English, not on Spanish. So a lot of the misinformation went through, and so a lot of these deceptive ads are directly targeted to Latinos. They're targeted to Latinos in Spanish. You can buy your Ozempic patches. There's no Ozempic patches. You have these influencers, Latino influencers, who are on TikTok and selling people these medications that are not real, that are literally made in a closet, that are made imported for research use only, which is basically made for lab animals and not for human beings. And again, we're seeing it sells. People are falling for it. People are continuing buying for it because they're desperate. We have people, again, when half the population is obese, they are not trying to get into that summer dress, or they're trying to go to the beach or whatever. They're using it just to stay alive. And so it's getting worse and worse. And think that's all I had. Oh, sorry. I can sit here and complain all day. A few people from our office here. My wonderful phrase, si hay trabajo, hay que trabajar. If there's work to be done. And I always say, there's one thing for me to complain about this stuff, but the other thing is like, if the market is targeting Latinos, then just use that social media to target Latinos and inform them properly. So one of the things we've been doing is a lot on that. We've been doing advocacy with state legislatures on Capitol Hill, and then we do our ferias de salud around the country. We have about 435 councils across the country, so that's what we do. And I think that's it.
Great. Thank you. And for the social media, LULAC's website is just lulac.org. So they have links to all the social media accounts as well. We are going to hold questions and answers for the end. So we're going to move on with our panel. But if people have questions, please save them, write them down, put them in your phone, and we'll take them at the end of the panel. So liver disease, including MASH, which stands for metabolic dysfunction associated steatohepatitis. I'm just going to go with MASH because it's a pretty long one. But it's rising rapidly in Latino communities, MASH. And so we are higher risk because of genetic factors, higher rates of obesity, as we've just talked about, and diabetes, and limited access to early screening. And so we're pleased to have on our panel Miss Sarah Von G. Truden joining us today, who is representing the Global Liver Institute. She is a healthcare and welfare policy expert with 30 years of experience. And today she's going to give us an overview of liver disease, MASH, and a bunch of stuff that I can't really pronounce. So we're really lucky to have her. Thank you.
Thank you. Yeah, the curse of marrying a Belgian is I got this very long last name. Anyway, but thank you all for letting me be here. Now I'm terrified after your presentation, because I think we're all aware of what's going on in the obesity community with compounded drugs. So thank you for that, and thank you for inviting me. This is such an honor and a pleasure to be here. So Global Liver Institute, I've been working with them for about 3 years now. And I often tell them, they're like 5 different patient groups in one, because liver disease is such a significant issue for so many populations. You really you've got fatty liver disease, you've got obesity, you've got liver cancer, which is the outcome of untreated liver disease. You've got hepatitis B and C. There's a wide breadth of issues that affect our livers, and I always tell people, as a liver patient myself, go get your liver looked at. It's important to do. Next slide. So, just generally speaking, I'll give you some of the big numbers. Right now, there are 115 million people worldwide who have fatty liver disease, and that is expected to become 357 million people by 2030. So this is really considered to be a looming epidemic for the world, not just the United States and not just for the Hispanic community. It's something that I think, when you talked about fast food in your presentation, it made me think about just how much work we have to do, both in the context of helping people access healthier food and otherwise. But specific to obesity, I think it's important to understand too that fatty liver disease and obesity are conditions that go hand in hand. And then getting into the acronyms, right, which is, I know a lot. But you have fatty liver disease, which is, so MASLD stands for metabolic dysfunction associated steatotic liver disease. It used to be called non-alcoholic fatty liver disease, which was a whole lot easier to pronounce. That's the early form of fatty liver disease. When we talk about the later form of fatty liver disease, the form of fatty liver disease that we're really trying to treat with new medications that have come to market, that's when we get into what's called MASH now. It's called metabolic dysfunction associated steatohepatitis, but it used to be called non-alcoholic steatohepatitis, NASH. So what was NAFLD and NASH is now MASLD and MASH. So just in case, I know that's very confusing, but these new acronyms, we've got to get used to some new acronyms because they've changed the name of the conditions. But I think it's important to understand that these conditions are associated with significant impairment. I've done a lot of interviews with patients who have fatty liver disease, and I think the number one thing you hear from them is just fatigue, right? They're so tired. They can't figure out why they're so tired. And oftentimes these conditions are overlooked by their clinicians. Clinicians are just not looking for fatty liver disease in patients. And so that's when you get into these patient-reported outcomes like health-related quality of life and work productivity. People wake up in the morning and they just don't feel like going to work. But the really devastating part of fatty liver disease is that when it goes undiagnosed, right, now you're going from, the earlier form of fatty liver disease to the later form of fatty liver disease, which is the form of fatty liver disease that now leads to cirrhosis, and cirrhosis leads to cancer or liver transplant. So it can be a really significant condition for a lot of patients. And we're doing our best, I think, and part of what I want to talk about today is getting access to that diagnosis and how important that is. The Hispanic community has an elevated risk of fatty liver disease. So this slide pretty much says it all. 47% of Hispanic adults have MASLD, which is the earlier form of fatty liver disease, which is higher than the percentages that we see in other populations. And so we're seeing those numbers increase. And what's also contributing to that is not just lifestyle. And when I was talking to Global Liver Institute and folks around about this and about today, they wanted me to emphasize that there's also a genetic risk that the Hispanic population faces in terms of fatty liver disease that's not shared necessarily by other populations. So I think that's something else that you have to also keep in the back of your head. And then it's important to also know that chronic liver disease ranks as one of the leading causes of death in the Hispanic and Latino population. And the underlying causes may or may not be related to alcohol. I think a lot of us, when we think about liver disease, we often go straight to alcohol, and alcohol can be a related factor, but it's not always a related factor. It can also be associated with the food that you're eating. It can also be associated with exposure to hepatitis B and C viruses, but it's almost always associated with, not almost, but it's highly associated with obesity. I'm having the same problem you were. Did I get it? There you go. And so this slide just talks a little bit more about the alcohol-associated liver disease. And I think what's important on this slide to understand is that for individuals who experience alcohol-related fatty liver disease, there's a higher risk of that leading to cirrhosis, and a higher risk of that then leading to acute liver failure, liver transplantation among Hispanics than their non-Hispanic counterparts. Too far. So as I was saying earlier in terms of diagnosis, this is something where Global Liver Institute's been really highly focused on something we call beyond the biopsy. Biopsies, while sometimes indicated to diagnose liver disease, are not always indicated. And in fact, if you look at the clinical guidelines, most clinical guidelines would recommend that you just get a simple image. You can detect liver disease with simple imaging procedures. Yet, what we've seen now is, and it's really come to a head because of new medications that are out there for the advanced forms of fatty liver disease. The VA, when they had originally put those drugs on their formularies, they said, we will only cover these drugs if you have a biopsy diagnosis, meaning that the patient had to go through a biopsy for the diagnosis before they would cover the drugs. This is something that Global Liver Institute's been fighting both at the plan level and in the VA. A lot of times plans will follow the VA, and so we're really trying to get this issue addressed because the primary and first stop really should be an image to diagnose the disease, not a very risky biopsy. So we had some report language in the House and Senate bills that were calling for the VA to advance use of more non-invasive technologies for diagnosis, and are going to continue to kind of beat the drum on this. So, in the context of obesity too, some of you may have been reading, it's been front page news, right, that obesity medications are going to be covered in Medicare. I have a whole document around what we think we know, because there's still a lot of questions around what the benefit's going to look like. But essentially what happened is that the president announced a negotiation with 2 of the manufacturers to establish discounts on obesity medications for consumers that are prescribed GLP-1s. So these are the forms that we're not getting through compounding pharmacies. And these would be delivered through what is going to be called the Trump RX platform. So the co-pays in Medicare, as we understand it, would be around $50 or less for patients, which would be a significant reduction in cost for patients. And thinking about this in the context of the earlier presentation, I would hope would lead to patients being able to access prescribed drugs and not have to go to those compounding pharmacies. And in Medicaid, we'll also have access to that lower rate if states choose to do so. And then for people who fall outside of the Medicare and Medicaid programs, there has also been indication that other people will also be able to potentially get these drugs in a direct consumer way through Trump RX. So potentially good news for patients to get lower prices for the products. There we go. But that doesn't mean that we don't want to codify coverage. I will tell you, as someone who worked on Capitol Hill back in the early 2000s, when we were working on a Part D benefit in Medicare, and I think people often forget that there wasn't always a drug benefit associated with Medicare for older adults and people with disabilities. That happened in 2003 through the Medicare Modernization Act. When we were working on the Medicare Modernization Act, a big mistake that a lot of people on Capitol Hill made, because at the time weight loss drugs were not very good, they included a provision in that bill that said essentially Medicare Part D was going to be barred from covering weight loss drugs. Well, now we have really good weight loss drugs on the market that are game-changing and really making a significant difference in people's lives and are much safer. So there's been an effort to change that law, to codify the changes that would allow Medicare to cover these drugs. We still feel like that's very important to do. It's great that the administration is moving in that direction through regulations, but it's only going to be a safe policy when it's codified by Congress. There we go. And I think it's important to point out how much nutrition does play a role in all of this. There are 2 different pieces of legislation that I wanted to highlight today. The Medical Foods and Formulas Act 2025 is legislation that would allow for coverage of the kinds of foods that are prescribed to people who have certain forms of liver disease where they don't process certain proteins correctly. And this isn't the kind of food you buy in a grocery store. This is the kind of food that doctors will prescribe to people with very serious liver disease. And then, next slide. And then there's also the Medicare, there's also the Therapy Act, which, let's skip that slide. And that's legislation that would allow for coverage of medical nutrition services through dietitians. And this slide is talking about the Medicare Multi-Cancer Early Detection Screening Coverage Act, which I know is also a mouthful. As I mentioned, as a patient myself, this is a really interesting and important, I think, test. This new test that has come to market it's just a simple blood test. You go to Quest and get your blood taken, send it in, and it will tell you if you have evidence of cancer in your blood system. It is most effective for liver cancer diagnoses. And with the increase, liver cancer is one of those cancers that's rising, not falling. Why? Because of the significance of fatty liver disease, which is now leading more patients to liver cancer. So we think that it's very important for this to be covered under Medicare, this test, and are going to continue to support it. And so I'll wrap it up there. I know there's a lot more that I'm sure we could cover, but those are the highlights. Thank you.
Thank you, Sarah. Thank you. Mental health is another critical yet often overlooked aspect to well-being and health in our communities. Conditions like can have profound impact on individuals and families. We're welcoming today Dr. Jaden Dickinson, who's a medical science liaison at Bristol Myers Squibb. She is a board certified psychiatric pharmacist and an active member of the American Association of Psychiatric Pharmacists, and will speak about mental health with an emphasis on schizophrenia. Among Latinos. Welcome, Dr. Dickinson.
Thank you. Yeah, that's a mouthful. You guys can hear me. Hopefully. Again, my name is Jaden. Thank you guys so much for having me. I'm really excited to be here. I am a board certified psychiatric pharmacist by trade. So before my time at Bristol Myers Squibb, I was actually a clinical pharmacy specialist in psychiatry at a forensic hospital in Perkins, where I primarily treated minority patients with schizophrenia and bipolar disorder. And I was residency trained in South Florida, so I had a lot of Hispanic and Latino patients down there. And that's pretty much all I've really done with my career is really severe mental illness. So I'm really excited to be here today to talk about some of the issues that Hispanic and Latino patients face. Sorry again. Okay, so when we look at the epidemiology and burden of schizophrenia, schizophrenia itself affects about 1 in 300 people worldwide. Now, in the US, it's about 1%, so 1 in 100, and it affects 1 in 5 Hispanic patients that have a mental illness. So this is any mental illness. When we think about severe mental illness, it's 1 in 20 Hispanic and Latino patients have a severe mental illness. Schizophrenia specifically is one of the top 15 leading causes of disability. It causes impaired relationships, inability to integrate into the community, difficulties with work, with school. It causes severe impairment. And patients with schizophrenia have a reduced life expectancy of almost 30 years, 30. That's a significant amount of time and years lost off their life. Now, the diagnosis of schizophrenia generally comes in the late teen and early adult time, and the longer someone goes untreated, the poorer outcomes they are likely to have. Now, the Hispanic and Latino population tend to get misdiagnosed, and what this ends up doing is prolonging that time to diagnosis can worsen those long-term outcomes. Now, there's many reasons for why this can happen, and we'll touch on that. It could be health literacy issues. It could be maybe cultural issues where people don't want to speak up about their mental health, or depending on if there's an interpreter or if a psychiatrist or doctor understands what's going on with the patient, they may actually misdiagnose them with something else. Maybe it's trauma. They think it's trauma related. Maybe they think it's bipolar. There's a lot of different factors that can go into a misdiagnosis, but you do see it frequently in practice. So this is a public health metric. It looks at years lived with disability, and really what I want you to take away from this slide is you can see schizophrenia is on top here. There is no cure for schizophrenia. What we have currently are medications to manage the symptoms of schizophrenia, but no current cure for schizophrenia exists at this time. Next slide, please. Individuals that get diagnosed with schizophrenia do face substantial disease burden. In terms of comorbidities, 66% of hospitalized people with schizophrenia have at least one comorbidity. And I know I won't get into medical comorbidities because we did talk about weight gain and obesity, but yes, Hispanic patients may have an increased risk of gaining weight, and some of the medications that we use to treat schizophrenia can increase obesity and weight gain. So it's kind of this snowball effect that can worsen with treatment currently. Schizophrenia can cause social dysfunction. You see a lot of patients with schizophrenia have issues maintaining relationships with family, with friends, being able to carry on a job, go to school, employment. It's very hard for them to keep a job, and a significant number of schizophrenia diagnosed patients are homeless. Now, when we look at this, some of the statistics I looked at were up to 20% of Hispanic patients are uninsured. So, do we think that they are getting the proper care if they don't have health insurance for their mental health? Probably not. And lastly, incarceration. So about 10% of patients that are incarcerated are diagnosed with schizophrenia. Now, obviously, I want to talk about caregiver burden here because caregiver support is, one of the most important factors for successful, success for schizophrenia diagnosed patients. Caregivers do take on a significant burden, though, and especially in the Hispanic population, a lot of Hispanic culture is very family oriented. Now, this can be, either a very positive thing when we think about the support that they provide to their family members, but if caregivers, aren't believing in mental health services, they may discourage family members from seeking the help that they need. So it's important that we provide that education and the support and the resources for these patients and meet them where their health literacy is at so they can understand the importance of treatment. Next slide, please. Looking at mortality in schizophrenia, the best way I could put this is most or a majority of schizophrenia patients will die before their geriatric years. Think about that. Schizophrenia patients lose about 30 years off of their life, which is a significant amount of time. And this could be due to natural causes, diabetes, renal failure, cardiovascular disease, so issues that affect your heart, different cancers, or unnatural causes like suicide, accidents, so on. Next slide. This is another way to look at all-cause death and suicide in schizophrenia. About 5% of patients diagnosed with schizophrenia will commit suicide in their lifetime. But you can see schizophrenia all the way on the left. The purple bar will be all deaths, and then suicide will be in the dark gray bar next to it. And this is the highest rate of deaths compared to other mental illnesses. Again, schizophrenia has significant comorbidities. We talked about cardiometabolic, so cardio meaning your heart, so long-term heart disease. Not only can patients with schizophrenia have long-term heart disease, but some of the medications can worsen and cause long-term heart disease. 2/3 of patients with schizophrenia will have this comorbidity. And with diabetes, we talked about the increased risk that not only schizophrenia patients have, but Hispanic patients have as well. Patients have a 2 to 3 times higher risk of developing diabetes than patients without schizophrenia. I touched on cancer, kidney disease as well, and other psychiatric disorders. When we think about things that worsen these comorbidities, maybe lack of physical activity, lack of exercise, is there access to this? Is there access to a healthy diet, fresh food? I know we just heard that some areas don't have grocery stores and they're eating fast food. Do they have access to resources, to primary care? Can they pay for not only mental health meds, but can they pay for regular maintenance meds for non-mental health, indications? And for some patients, that answer is no. So we need to think about what is going to be worsened in this Hispanic population, and we need to improve their medication adherence, get them on appropriate meds, mental health and medical meds, and educate them on the importance of continuing these medications.
Yeah. Perfect. So we're going to take a quick pause. So thank you, Jaden. We'll get back to you in a second. But we're pleased to have Congressman Juan Ciscomani, who represents Arizona's 6th congressional district, here joining us today. So thank you and welcome.
Thank you. Well, thank you. Sorry to interrupt. I promise I'll be brief, and you can continue. Did you hear what I said? Because my microphone. Okay, great. Thank you so much. There we go. Well, thank you. Buenos días. Muy bien. Ahí sí. Igual soy de Arizona y en Tucson cuando digo good morning nadie me contesta. Entonces digo buenos días y todos me contestan. O sea que muy bien. Pues gracias por estar aquí. Thank you so much for joining us. Thank you to the panel as well. I know it's a day full of learning and to talk about this important issue, which is obviously our senior issues and healthcare and everything that contains with our seniors, especially in our Hispanic community. Es un tema muy importante de poder tratar de los temas con las personas de edad más avanzada y específicamente con nuestra comunidad hispana, que tiene temas y retos y oportunidades muy particulares a nuestra comunidad. So I want to thank everyone for that. You know, it's not too often that we get to prioritize Hispanic seniors so specifically as we do here. Our senior and Hispanic communities face very unique health needs, as we all know it. That's what I was just saying in Spanish, that the needs for our Hispanic community are very, very particular, especially among seniors. And so, you know, in terms of why I'm here, you heard I spoke Spanish. I was born in Mexico. Yo nací en México. And I immigrated to the U.S. when I was 11 years old. Emigré aquí a Estados Unidos cuando tenía 11 años. Then I became a U.S. citizen in 2006. 16 years later, I was elected to be as a member of the United States Congress. So I believe in the American dream. I believe in the opportunities this amazing nation offers. Mis padres emigraron aquí al país cuando yo tenía 11 años, me hice ciudadano en el 2006 y 16 años después, congresista de Estados Unidos. Es un país lleno de oportunidades, un país lleno de oportunidad para todo aquel que quiera tener esa oportunidad. However, when we talk about the American dream, healthcare is a big, big part of that. That is one of the things that obviously keeps us healthy and keeps us going to be able to pursue that American dream. And that's why I'm so passionate about this. Both my parents, which I think now, the older I get, the younger my parents seem to be, right? So I used to think that their age was old back when they were 40 years old. Well, now I think that's extremely young. But my parents that are in their late 60s, which I, again, think it's fairly old, but my dad is recently retired. My dad has had some severe health issues, and that has required us to face the reality of healthcare for people like him in this country. And that has opened up my eyes to that reality. So that made me even more passionate about the work that we're able to do. So I'm proud to have sponsored the Elizabeth Dole Act. The flagship VA reform legislation last Congress includes caregiver support program and investment as well. Co-sponsor the Women in Lung Cancer Research and Preventive Service Act. This is for Hispanic women that have a higher risk of many cancers. My mom also, my mom's mom, so my grandmother, passed away. Never met her, obviously, when my mom was 7 years old in Mexico. So then my mom had her own episode and incident with breast cancer as well. It runs rampant in my side of my mom's family. So this is something that we've also been very much faced with. And then I co-led the FASTER Act to help seniors, senior falls at home, which is a very, very big deal to be paying attention to. So I'm glad to play a small role here while in Congress, working with the administration on addressing chronic health care needs as well and supporting investments in disease research through the Appropriations Committee. In Arizona, I'm the only one in the Appropriations Committee, both House and Senate. So I take that responsibility very seriously, and I'm committed to continuing to support greater investment in these critical industries, research, and services that our seniors rely on. Y para concluir y poder seguir con el programa, nomás les quiero dar las gracias por estar aquí y seguir luchando por esto. Tienen un amigo en mí, un socio en mí para seguir luchando por estos temas. Necesitamos invertir más en estas oportunidades para poder ayudar a nuestra comunidad de ancianos, pero también, obviamente, específicamente hispanos. So I want to thank you just as I conclude here for your advocacy, for your work, for what you're fighting for, and for identifying and knowing the need and that is so great within our senior population, but also even more specific among Hispanic seniors, because we have cultural issues as well that play a role into how we approach healthcare and how we take care of our own and how we bring our parents. And I know like I mentioned, when my dad had those healthcare issues, we stuck together, we brought him in, we moved into their house, we did what we had to do to advance all this. That's very particular, I think, to our community. So thank you for the work that you do. Thank you for being here in Washington, D.C. on this beautiful day. Please keep up the work and know that you have a partner and a friend in me. So thank you so much. God bless you all.
Perfect, thank you. All right. So I know that we just talked about a lot of the comorbidities, and I'm trying to get back on track here. But a lot of those, the weight gain and all of these other cardiovascular issues, homelessness, a lot of these contribute to the reduced life years that patients with schizophrenia experience. When we look at substance use disorders, the next 3 slides are going to, talk about different substance use disorders, smoking and cannabis. But substance use disorder, there are high rates of different substance use in patients with schizophrenia. You can see here about 40% of schizophrenia diagnosed patients also have a concurrent substance use disorder. And this can lead to, again, higher mortality rates, more severe symptoms of schizophrenia and hospitalizations, poor treatment adherence. When patients are not adherent to their meds, they have a greater risk of relapse, meaning they are more likely to go to the hospital to get treated. When this happens, it's not only more difficult to treat them, they tend to need higher doses of meds and or more medication. And so the importance of patients staying on their medications can prevent some of these, 1, comorbidities, but 2, maybe the life risk reduction. The one thing I'll add here is that when we think about substance use disorders, we obviously try to treat them. We obviously try to treat them when patients are diagnosed, but for Hispanic and Latino patients, if they do not have access to mental health providers or the proper care, they might not also be able to get substance use disorder treatment as well. Cannabis, again, it's similarly here, increased risk for relapse, hospital stays, poor prognosis. And then on the next slide, it'll pretty much say the same thing in smoking as well. But what I want to end with, you can go on the last slide, please, is stigma. And there's a lot of things, revolving around stigma in the world of mental health, and there's therapeutic programs that we can use to improve the stigma. We can see that schizophrenia itself is one of the most stigmatized mental health illnesses, and you see it in communities, in schools, in the workplace. And stigma leads to things like loneliness, suicide, poor treatment adherence. So how can we reduce the stigma? Now, I did a lot of research, especially with an organization called NAMI, the National Alliance for Mental Illness. And there are high rates of, the Hispanic culture not wanting to talk about these issues for fears of stigma. Maybe it's culturally related, maybe it's religiously related. But having those considerations and making sure we're educating on the importance of mental health and how can we integrate the treatment of mental health to also meet the cultural needs of this population, I think, is a barrier we have yet to address. The couple last things I'll leave you with. Stigma also, Hispanics are one of the, when we think about clinical trial demographics, they're the most underrepresented patient population, one of the most underrepresented patient populations in clinical trials for medications. And again, maybe this is due to stigma, maybe this is due to a decreased health literacy, maybe there's a language barrier, but we need to get them, the education and the services that they need. SAMHSA in 2023 said only 36% of Hispanic and Latinos use mental health services versus over 50% of white patients. So there is a significant difference there. And so what I want to leave you with is we need to think about decreasing cultural and structural barriers. We need to find resources to provide, the Hispanic population appropriate care, whether even be primary care, mental health, increase their education, expand these services, find more providers that, are able to speak and communicate with them bilingually or use interpreter services that understand the cultural differences, and maybe then we can help to reduce some of that stigma.
Thank you, thank you. Some of you guys may have heard the buzzing during that presentation, and this is just a reminder we are on Capitol Hill. So if you notice the clock and you hear it buzz, that's because there's a vote. And so it's probably going to buzz every, there's 10 minutes left of the vote, 5 minutes left in the vote. You're going to hear it buzzing throughout this presentation. And just so you know, that's what it is. They're calling votes because we're here on Capitol Hill. And so when I hear presentations like that, I think it's important to remember, schizophrenia, and I was talking to a researcher on Alzheimer's the other day. These diseases affect Republicans, they affect Democrats, they affect poor people, middle-class people, wealthy people. And so, being on Capitol Hill, we have an opportunity to talk to lawmakers, tell them how important it is to have research, to have programs that make drugs affordable, and other important services. And so next, we are going to talk about the 340B program to make drugs affordable for our community. And so that's a program that allows eligible healthcare providers, particularly those serving underserved communities like Latino communities, to purchase outpatient drugs at reduced prices. Today, Mr. Johnson, who is the Executive Director of ASAP 340B, which is an organization concerned with ensuring the viability of the 340B program, he's going to provide an overview about the importance of reforming this program. So we welcome you here today, Mr. Johnson.
Thank you very much. Appreciate it. Good morning, everyone. And I want to try and go through this program, which is a very important program for the underserved, but also walk through how Washington is looking at this program and some of the concerns, specific concerns that we have about certain actors, frankly, taking advantage of this program because of a lack of clarity in a number of areas. Next slide. So our coalition represents 41 organizations. We've been around for about 2.5 years. We started off with 17 organizations. Our two main members are the National Association of Community Health Centers and PhRMA. We are continuing to grow as we spread the message about 340B reform. I'm also happy to let you know that the National Hispanic Council on Aging, LULAC, and the Global Liver Institute, who are all here, are all members of our coalition. Next slide. So we've come together because this program, which is an important program and a program that we support, it's been around for over 30 years to help low-income and other vulnerable patients provide affordable medicines to those who need access to those medicines. Community health centers and other safety net providers rely on this program to serve their communities, but some of the entities participating in this program have taken advantage of it, quite frankly. And because of a lack of clarity in the statute, this is happening at the expense of patients it's meant to serve. And the well-being of these communities served by our country's healthcare safety net is at stake. Next slide. So this is an idea of what's supposed to happen in the 340B program. As stated previously, this is a program for outpatient drugs that serves certain types of covered entities. It allows them to purchase drugs at a discount. Right now, the discount is averaging about 59% of the cost of the drug. And the two main types of covered entities that acquire drugs under this program are hospitals and community health centers. So what's supposed to happen is that a covered entity purchases a drug at that discount of 59%. They are then eligible to bill Medicaid, Medicare, the private carrier for the full cost of the drug. And they are able to keep the difference to help them use their scarce resources to provide for those who are underserved. That's what's supposed to happen under the program. That's a good program. Unfortunately, what is happening now is that certain covered entities, and I will speak specifically to the hospital community, are acquiring those drugs in the same fashion as a discount. And instead of billing Medicaid, Medicare, and private carriers at that price, at acquisition price, they are now charging in some cases 500 to 1,000% of the cost of the drug that they acquired. So they are now starting to use this program as a profit center instead of a program that's supposed to serve the underserved. And that's creating some incentives that we think go against the nature of the program. And in the same fashion, the covered entity keeps a difference. Only it's not that 41%. It's now potentially 500 to 1,000%. Next one. So in many cases, although we support this program, the program is not working as intended. It's grown significantly. The number of covered entities have grown. And unfortunately, we have hospitals and middlemen such as PBMs that are starting to distort the program and take advantage of the program. As you can see on the pie chart, 87% of the drugs purchased in this program are purchased by hospitals and hospital systems. The next highest percentage purchased by community health centers is 5%. So a total of $66.3 billion were purchased under this program in 2023, making it the second largest prescription drug discount program in the country. There are few transparency and accountability measures in this program. I'm going to talk about that in a later slide, but you will see when you go back to that 87% figure, how hard it is to get data as to who's actually benefiting from this program. Currently, without the clarity that we need for this program and with these practices, hospital consolidation is increasing, and this program actually encourages that, encourages hospitals to acquire other types of covered entities and extend that benefit to those covered entities. As stated, PBMs and other middlemen are siphoning billions from this program, as last reported to the tune of $2.53 billion in 2023. Next slide. Washington is starting to pay attention to this program. There has been legislation introduced. There are groups that are working on this program to try and come up with comprehensive solutions. Senator Cassidy, who chairs the Senate Health Committee, came out with a report in April about some of the reforms that are needed for this program. One of the major reforms that's needed is to make sure that there's consistent transparency amongst all types of covered entities so that we can actually pull the data from this program and see who this benefit is going to and what money is being used for. There are reports of money that's being used for not for patient care, but in some cases for capital improvement projects. In one case for a Super Bowl ad, and in one case to pay a salary of a football coach. So this year, there's been more and more talk about what to do about this program. And looking into next year, one thing that the Trump administration has decided to look at, they are launching a voluntary pilot program where they will look at 10 drugs under the program that are used in the 340B program and make it a rebate program instead of what's in its current form. So that essentially covered entities would have to purchase those drugs at the actual cost and then receive a rebate afterwards. Now, our coalition has not taken a position as it relates to this voluntary pilot. And looks like there's going to be some litigation in the future about this pilot, but this is something that's happening at the beginning of next year. Next slide. So just some quotes from Senator Cassidy and a report that he released in April about what's happening with regards to this program. He outlined a couple of covered entities, first being the Cleveland Clinic. They generated nearly $1 billion in 340B revenue from April 2020 through June 2023. None of it was passed directly to patients. Instead, it was absorbed into operating budgets and capital projects. Next slide. Bon Secours Mercy Health in Richmond. Despite being located in one of Richmond's poorest communities, Bon Secours used its 340B profits to fund expansion in wealthier and more affluent areas. Patients did not see a direct benefit from the savings. Next slide. Sun River generated over $100 million through 340B, primarily from AIDS, HIV/AIDS, diabetes, and hepatitis C medications. Next slide. So there's a differing accountability with regards to hospitals and other types of covered entities. Many of the covered entities are HRSA grantees, which means they are required to report on 340B revenue and what they spend that money on. Hospitals are not HRSA grantees, and therefore they are not required to make such reports. And when you're talking about 87% of the purchases in this program, you are talking about a vast difference in reporting accountability between hospitals and other types of covered entities. Next slide. 340B hospitals provide less charity care, even though they are receiving dollars under this program, and they also receive tax advantages under this program. So you look at 340B hospitals, 2.15% going towards charity care, nonprofit hospitals 2.3%, for-profit hospitals 3.8%. Next slide. In the area of cancer, which is a leading cause of death for Latinos and African Americans, there have been reports released by various groups that really outline some of the abuses that are taking place with regards to overpricing of drugs for cancer patients. The American Cancer Society issued a report showing that 340B hospitals use higher cost cancer drugs, and cancer therapies were over 10 times higher in terms of cost than at non-340B hospitals, even though they're receiving that discount. The state of North Carolina reported that 340B hospitals charge state employees more than 5 times their cost for cancer drugs, an 84.8% markup. And the New York Times specifically, this is just an example, there was a patient whose covered entity, the covered entity that was serving them, that covered entity received a discount on a $5,000 drug. They acquired the drug for $2,700. They then turned around and billed Medicaid $22,700 for that drug. They received $10,000, and then they still turned around and billed that same patient $2,700. The way the law works right now, they are allowed to do that. So there are a number of groups besides our coalition that are also urging Congress to take action and work towards reform. Those groups are outlined. Next slide. There are a number of Latino organizations in our coalition, including not only the LULAC and the National Hispanic Council on Aging, but also the National Association of Hispanic Nurses, the National Hispanic Health Foundation, and the Organization for Latino Health Advocacy. Next slide. Our solutions look towards ensuring that savings are used to help patients and true safety net providers prevent abuse by middlemen and verify that this program is working through transparency. Thank you very much.
All right, thank you. Our final topic for today is going to be Medicare Advantage. And while these plans could offer extra benefits, as I'm sure some of you know, these plans could also pose challenges to many people, including limited provider networks or prior authorization requirements that could really impact people's ability to get timely treatment. So to learn more about this topic, we are delighted today to be joined by Ms. Sohini Gupta, who is the Executive Vice President for Government Affairs and Innovations at AHIP, and she is joining us today to highlight Medicare Advantage and access to care with a focus on chronic illnesses. Thank you.
Great, thank you so much, and thank you, Dr. Cruz, for having us here. We very much appreciate the partnership that we have with NHCOA and look forward to its continued growth. So I know I'm keeping all of you from being able to get answers to questions that you've been sitting on, and then also next up is the important work that you all will be doing today by sharing your story directly with policymakers. So I'll just take a few minutes here to chat with you about your health insurance coverage and Medicare Advantage. Just a little bit about AHIP. We're an organization, we're a trade association. You may hear that term a lot here in Washington, D.C., which means that we're the collective voice on behalf of the health insurance industry. Overall, AHIP represents over 205 million lives. We have over 120 members that range from the biggest insurance providers to also your very small and localized plans. And we just take enormous pride in our ability to make sure that the healthcare system is focused on healthcare outcomes, that we can decrease costs, and more importantly, make healthcare affordable, because we know it takes on a lot of risk and it can cost a lot. That is one thing there seems to be agreement on in Congress, is that healthcare is expensive, and we need to continue to make sure that it's accessible by making it affordable. So our mantra is guiding greater health, and we are focused on working with the whole healthcare system to do that. But just a little bit more about Medicare Advantage. Sarah here reminded me of our great work together on the Hill, which created the Part D benefit, but also embedded more broadly the Medicare Advantage program and made it really part of an offering through Medicare. And so Medicare Advantage, you may not know whether that's your plan or not, but it is a choice that you elect. And you all just went through your open enrollment period recently, and it sits alongside what people call, fee-for-service or traditional Medicare, where Medicare Advantage can offer a lot of other benefits that traditional Medicare cannot, just because of the efficiencies. But who does it serve? We are the majority of the Medicare program now. Over 54% of Medicare eligible people, that means seniors and those with disabilities, choose Medicare Advantage. And that's 35 million seniors in total. We also serve a larger share of low-income population. We serve more dually eligible folks than traditional fee-for-service, and our populations tend to be less healthy and more diverse. And so we take care and making sure that those underserved populations and communities have an option that really takes care of the person as a whole and isn't necessarily just based on utilization, but what we term, value-based care. Oh, and then I will point out that 57% of females that are eligible for Medicare choose Medicare Advantage. We'll dive a little deeper in terms of the Hispanic population as well, but that's just a big overview of the program. Then if we just think about why folks might choose Medicare Advantage more, I think it's an easy choice, but if you look at sort of the comparisons, it really is because of the robust benefits that can be provided. There are two key differences I like to highlight. One, under Medicare Advantage, your out-of-pocket costs are capped. So there is a maximum that an individual can spend when they're under the Medicare Advantage program. And that does not exist under the fee-for-service program. So that saves seniors about $3,400 a year, knowing that they don't have to do that. In addition, there's integrated coordinated care that I like to mention, which really is supplemental benefits, which means that if you need food to take with your medicine, if you need a ramp to be put in place in your home so that there's easy access, for transportation to occur, to decrease loneliness and create more community connectivity, exercise, that all can be provided under the Medicare Advantage program, where traditional fee-for-service doesn't have the efficiencies in order to be able to provide them. So that's the comparison between the two, but just really I like to focus in on the cost piece, which we just talked about, but also the value in terms of the outcomes. It's just really important that we think about what the program can actually obtain for people that are on it. In Congress, there's a lot of focus on money. So this slide's here just to make sure everyone knows that compared to the fee-for-service program, Medicare Advantage is also taking care of the government as a customer. We are doing right by taxpayer dollars. It decreases the overall impact on the Medicare Trust Fund, extending its solvency, and that it costs less. And so you may hear a lot of different noise about figures as people talk about Medicare Advantage versus fee-for-service. But if you were to really look at what we call an apples-to-apples comparison, the same things, Medicare Advantage saves the government 9.8% over traditional fee-for-service. So just have that in your minds. There's a reason why seniors choose it. It's less expensive for seniors, but it also is the better choice for the government. And how does it do that? It doesn't do it by decreasing benefit offerings. Like I mentioned, there's supplemental benefits. It does it by making sure that there's fewer hospital readmissions, their enhanced quality, that you're utilizing and have access to providers that can take care of you outside the hospital system, and that it also decreases inpatient costs as well by providing those supports. So let's just dive deeper a little bit on the figures that might translate to the Hispanic community and why traditionally the Hispanic community chooses MA plans. 61% of Hispanics that are eligible for Medicare choose Medicare Advantage. And I think it is really because of those supports that come along with the program. In addition, 70% of Medicare Advantage enrollees use one or more supplemental benefits. And among enrollees of color, so Hispanic and Black MA enrollees, they're more likely to use it, even higher than that 70%. Hispanic adults are 13% more likely to be diagnosed with diabetes. I mean, that's a statistic we're all, not going to continue to accept. We want to combat that, but there's consistency, right? Chronic care is extremely important when it comes to serving the Hispanic population, and we need to make sure that care is coordinated. Special needs plans. Those plans are ones that deal with people who have more than one multiple chronic condition, and that means there's a high intensity of care provided for folks that are under those plans. And so 21% of Medicare Advantage enrollees are in this high intense plan. So it is not that the Medicare Advantage program is serving folks that are just healthy, just want to it's serving folks that are harder to serve because the private sector knows how to provide the benefits that move the needle. So just diving a little bit deeper for you guys, just in case I get questions on the different offerings. We've got the special supplemental benefits for chronically ill that we talked about, and that can be food, meals, transportation, housing, utility supports. But I like to also highlight things like just the Silver Sneakers program, just because it does bring folks together. My parents actually exercise together every day, 4 times a week at their local gym through the Silver Sneakers program, and the increase in their energy, but also their just joy every day has been immense. So these benefits are tangible. They're not things that are just checklists. And I think that we talked about food and how food can impact health. And so I just mentioned 84% availability of food through special needs plans. I think that's a very big added benefit. So I kind of sound like I'm giving a commercial on Medicare Advantage, but the program, I will say, is a bit misunderstood. Seniors keep selecting it, and like I just said, those in the Hispanic community selected even more. But Congress is still has concerns, and so we'll talk about the policy recommendations. But I do want you to know that the industry, Medicare Advantage plans, take our consumer feedback very seriously. And that's not just, the senior, but the provider and the others that we engage with. And so there are a few things that we're doing that I want to make sure to improve. You can always improve. We know that. We think the operations aren't perfect. We know that there's bad actors in the system that we all need to guard against. And so as much as I'm touting the benefit of the program, I want you to know there are policy things that we're promoting and that we're doing to make sure that we're good stewards of the government's money, your money, and your health. So on the things that we're doing, I mentioned prior authorization. The industry unveiled, with AHIP's leadership, a prior authorization initiative in conjunction with members of Congress were there, and the administration was there, kind of to hold us accountable. But we've agreed on our own voluntarily to do a series of things in order to streamline the prior authorization process, in order to continue to even make it more focused on areas where there might be clinical differentiation and not a standard of care. And so decrease the number of claims. Make sure that if you change your plan, you don't have to go through the prior authorization process again. Also, for certain conditions where we know that those medications are going to need to continue, think about what to do there to streamline that process. Making sure decisions have clinical input. That had been happening, but we recognize there needs to be more emphasis around that. So prior authorization is important. We want to make sure we protect folks. I don't know if you guys remember what was called the resource-based relative value scale under Medicare, and that was back in the 90s. And basically, it was utilization-based, and seniors were being poked and prodded because there was money to be made with every lab that was submitted. And so there needed to be protections put in place to make sure seniors weren't utilized as not just experiments, but utilized for gain, for financial gain, at the risk of infections that happen when you get too many blood tests that you don't need. And so prior authorization is an important tool to make sure you're getting the right care at the right time. But we can make it easier, and that's what that promise is. So I think you're going to see some changes. I know there's pending legislation out there on it. There's a lot of synergy, but I think when the industry can come together and fix things, it's far better, and you'll see it far faster than sometimes when the government has to get involved. So our policy recommendations, just real quick, would just be to make sure you protect your supplemental benefits. I think it's important to highlight those. So if there are ones that you enjoy in particular, make sure you share that. Sometimes there's skepticism on whether or not those are healthcare things. Should food be something? Should Meals on Wheels be something that's provided? Is that really a healthcare need and item? And we've learned it's all interconnected, but we need to emphasize that point. Is exercise something that should be provided under the Medicare Advantage program? So just make sure you tout supplemental benefits and the importance of that. I think there is critique on the MA plans. We obviously will always continue to improve, and we're at the table during conversations on things like coding and risk adjustment. But these home risk assessments are an important tool to make sure that you really understand what's happening with the person, right? Coming into the home gives you a lot of important information to make sure people stay healthy, fall prevention, recognizing conditions that can't be known to your provider in a 15-minute checkup. So we continue to value the tools that we have, but we're at the table to make sure that they're utilized the right way. And then I mentioned this apples to apples piece, and I'm kind of excited about it because after being in this field for like 27 years, we really need to use our data that we have now, right? And our capabilities of making not just predictive analysis, but like real time information based on what's really happening. And I think that's become even more important after COVID because things are different and we have to look at the data. And so this apples to apples bill that Representative Bean has introduced would basically be about transparency. Let's find out what fee for service really costs, and then let's compare it to the Medicare Advantage program. Let's not, just make rounding errors and assumptions on what costs are being calculated when that fee for service number goes in there. It'll help us make sure that the trust fund is around for as long as it needs to be around and not be able to play with the numbers, but also it makes accurate policy making. And so very excited that this apples to apples bill is out there so that we can actually look at the figures themselves and determine what costs us what. So I encourage you to take a look at that bill, and as you talk with members, showcase that Medicare Advantage wants to be transparent, outperforms fee for service, and is ready to compete to do that. Thank you.
Great, thank you. So before our concluding remarks, we have some time for some questions. So I will take the moderator's liberty to ask the first question as you guys think of yours, and then we'll go from there. So I have a question about Medicare Advantage. I am of Puerto Rican descent, and for example, Darren Soto just last week introduced a bill to expand access to the ACA health exchanges to Puerto Rico, and there's an effort to expand Medicare Advantage to the island. What would that mean to Puerto Ricans, to Puerto Rico, if we could expand Medicare Advantage there? Could you talk about that a little bit?
Yeah. So I should have mentioned just because there is a topic that's circulating all among us, and it is related very much to healthcare. And so, although it's not Medicare, you're probably gonna hear about it, and it may come up. But it's in the employer and marketplace side. It's on the marketplace side to extend the enhanced premium tax credits. And so folks that are pre-Medicare actually are very impacted by it. A couple that is 60 years old can maybe see their premiums go up to like $17,000. Like I shudder at even saying that. It's mortgages. I mean, it doesn't sound right, but because they're not eligible for Medicare yet, and because they're on the exchange, it would cost that much with the tax credits expiring. The tax credits expire, it becomes extremely affordable, and it goes down very significantly to very low digits. But that is being debated in Congress. We had the shutdown of government where Democrats were insisting that this tax credit be extended, so that became a very political part of the conversation. We're hoping that there'll be a bipartisan option soon. Tomorrow, Thursday, the Senate is voting on this, and the House has promised to have a vote likely before they leave next week. So that is very important to extend. I will say, you mentioned Puerto Rico, and the Medicare Advantage rates under Puerto Rico are very low. And so every year you'll see advocacy to increase those rates. There's an annual process for how Medicare Advantage rates get set. We call it the rate notice, and it happens in the early part of the year. So even though you just selected your benefits for this year, actuaries are hard at work trying to figure out plan designs for next year. February, we get proposed rates, sort of, and then April, there'll be the rates. And then insurance companies will create contracts and bid out what they can provide under those rates for Medicare Advantage. But in Puerto Rico, those rates are very low, and they've always lagged very low, which has put a lot of provider burden on access in the area. So there's continued advocacy to increase those rates. There's a desire, though, for that program because of the coordinated care that happens along with it and the supplemental benefits that are very robust in Puerto Rico. So we'll just continue to advocate for rates to be adequate so that benefits don't have to be cut.
Okay. And we'll take some questions from the audience. Did you have a...
Gracias, buenos días. Permítame saludar a este excelente panel y yo les voy a pedir al público que es mayormente adulto que los aplaudamos con las manos. Un fuerte aplauso a este panel. Y también con los pies. Con los pies también. Aplaudan con los pies. A ver. Aplaudimos manos y pies. Perfecto. La idea era que nos movamos un poquito. La pregunta. Indudablemente estamos aquí porque NHCOA hace un excelente trabajo con los adultos mayores y creo que ustedes nos han dado mucha información de cómo combinar los medicamentos con la ciencia que hoy en día está indicando. Ejercicio es medicina. Prescribimos ejercicio. A todos los panelistas les he escuchado decir que el movimiento, la actividad física y el ejercicio es bueno para la salud. Hacemos.
Yes, first of all, I just wanted to greet all of the panel and all of the senior citizens. Thank you so much for all of the discourse and all of the great information. I mean, the reason for why I made everybody clap and clap with their hands and with their feet was just so that they can move a little bit, you know, and they can get some exercise going. But the question here undoubtedly is appreciate NHCOA for the excellent work that they have performed with the senior citizens. That have provided a lot of very useful information, and how you also put forward all of these ideas and information in regards to how we have combined science with exercise, indicating that exercise itself is a prescription in itself, and how we should prescribe the sense of exercising and for patients to be more aware of exercising itself. And I noticed how each one of the panelists have brought this forward. Mm-hmm.
Bueno, solamente para culminar, y discúlpenme, pensé que estaba haciendo la traducción simultánea. Solamente teniendo en cuenta que el 100% del ser humano se divide en 27% genéticamente, 11% beneficios de salud desde las vacunas desde que nacemos, 19% todo lo que significa el ambiente, mal llamado medio ambiente, el ambiente en general, cuidados en la casa y en la calle, pero el 43% está en nosotros.
I'm sorry, I thought that you were receiving a simultaneous interpretation, but I'm going to culminate and be very brief just to end this, since I wanted to split and break down how how the health system and how health in ourselves is composed and is divided. And I believe that it's 27% genetic, 11% is the benefit from the healthcare system itself that relies on the vaccines, for example, from the very moment that we are born, among many other medicines that we take throughout our lifetimes. 19% is based on an environment, the general environment, the care that we get out and about, and as well as in our households. And 43% is on us.
A nuestros adultos mayores no le podemos quitar la medicina.
We cannot take away the medicine from our seniors.
Le podemos dar más actividad física, más movimiento para que por acciones transversales el movimiento llegue a mejorar la salud mental, a mejorar la sociabilización que tanto lo necesitan, a mejorar una sana alimentación. Eso será posible, se los dejo como pregunta, porque creo que acá la población adulta está ávido de saber cómo puede combinar sus medicamentos, que no se los quiten porque ellos confían en la ciencia de la salud, pero también hoy en día el ejercicio físico dicen que es medicina. Entonces, si tenemos la actividad física y el ejercicio físico como medicina, ¿cómo combinamos para mejorar nuestra salud? Gracias y disculpen por la extensión.
I mean, and our senior citizens, they need to have more physical activity. They need to have more movement, and this goes hand in hand with our mental capacity and mental health, and how we also interact at a social sphere, at a social level. And the same goes with our way, the way we feed ourselves. We just to culminate, I just want to finish up with this, and because everybody here is eager to know know how we can combine the medicine that's available for us and the science that we so trust. How can we consolidate and combine all of this in order for us to grow healthier and to be more aligned with all of the benefits that health that this medicine and exercise combined have to offer.
Thank you. I mean, the issue, I think, for Latinos is it's a question of what is acculturation. Like, we look at, from, many of us come from either immigrants or come from immigrants, come from lifestyles that were very different than what we see here now, like what we experience. You probably have heard me give my story, like my mother's grandmother, who lived up to 102 years old, my mother's mother, who lived up to 109. Both grandma and great grandmother were born in a rancho, Mexico, with no running water, no electricity. But they lived up to 102 and 109. But mom, who was born in Westlake, Texas, raised in the United States, dies at 73, 35 years less. And it makes no sense that you would see that people would come to this country for a better life and yet have a shorter life. And part of it is, in the rancho, you would go walking, right? In the evenings, you would go for this, you would go. It was just, life is harder. But there was a different diet, there's a different lifestyle, there's a different, and you come to a city, and my mom worked 16-hour days. All she knew was just working. So every time she would work, and it wasn't necessarily exercise, it was just work. And so you work and you work and you work, the stress that comes with that, the lifestyle, the lack of exercise, the diet. No one wants to eat McDonald's every single day. But they do it because they're on the rush. They're rushing to go to the construction site. They're rushing to go to landscaping. They're rushing to go to something. They're trying to get things on the go. And again, this is not our diet. This is not our lifestyle. We have to adjust, but we also have to keep in mind that, like, what we're seeing in front of us, the neighborhoods that we live in, the food environments that we live in, the lack of exercise that we live in, that will kill us. Again, I go from a family of 109, 102 to 73. That should not happen. But again, is part of it is our failure or our inability to adjust to a new lifestyle that we see in the United States that is harsher, that is more stressful, and it really is relying on money and relying on just limited time. So for Latinos, we're a working class community, and so we struggle. So, obviously.
Great, thank you. And we're going to turn for our concluding remarks, but some of the panelists, I hope you could stick around a little bit after if people have additional questions. I'm happy to answer questions about policy. If it's about, liver disease, please ask our experts, and not me, but I'm happy to answer policy questions for folks. Before we end today, I would like to welcome Ms. Lorena Curry, who's the Inclusion and Community Impact Lead at Bristol Myers Squibb, and she is going to be sharing some closing remarks.
Thank you. Thank you, Jeff, and thank you, everyone. Thank you, Dr. Cruz. Thank you, NHCOA. Thank you to our esteemed panelists. Y muchas gracias a ustedes también por estar aquí, acompañándonos y entendiendo mejor cómo podemos trabajar con ustedes y por ustedes. My name is Lorena Curi. As Jeff mentioned, I am an Inclusion and Community Impact Lead for Bristol Myers Squibb, where health equity and access for all is not only a priority, but embedded in the way we work. We know from research that there are persistent health disparities rooted in many aspects: socioeconomic, linguistic. It's not only about the language, but the message and the messenger itself, cultural barriers within the US. And the latest SHOAR report explained how Hispanic and Latino older adults continue to experience higher rates of chronic diseases, financial hardship, and limited access to culturally competent care. And we heard it right now. ¿Y eso qué? ¿Y qué estamos haciendo? ¿Y qué podemos hacer? So we're trying to be better as an ecosystem in how we respond to your needs. Last year, Bristol Myers Squibb ran research on understanding the journey of Hispanic and Latino patients. And it showed how 51% of Hispanic adults deferred care because of affordability reasons or simply because being out of network covered by their insurance. Similarly, it reminded us the impact that the level of trust or concordance factor that we have between someone who speaks our language, who looks like us, who has an accent, has in the way we receive care. However, only 7% of medical professionals in the US identify themselves as Hispanic or Latinos, right? And that is not enough if our population is rapidly growing. So there is a significant gap in how we are seen and heard as patients. Now, looking into heart disease, everything that was said is so important because this is the second leading cause of death among Hispanics. Yet we heard about liver disease, we heard about like the growing issue with obesity. So a lot of the impact of social determinants of health and access to exercise, access to safe spaces, access to mental health services may also be impacting how we live today. Similarly, mental health is overlooked. My colleague Jaden spoke very highly about all the clinical manifestations, but she also mentioned the big stigma that we have as a community. We don't talk about Bruno, right? Like, no le digas a nadie que en tu familia y eso. So what are we gonna do about that? We're trying to make sure that there are more opportunities for each and every of us to move forward and treating all of these diseases. This is one of the reasons why community engagement is so important for us at Bristol Myers Squibb and everyone outside in the industry. All of my colleagues, we all collaborate on this and we partner with each other to make sure that we offer different spaces for you. Different opportunities such as mobile exhibits, where we talk about clinical trial education, mobile education units, Spanish language education, TV modules en español, los sábados en Telemundo a las 11:30. You guys can see Tu Salud, Tu Familia with Dr. Fabian Sandoval. So I invite you all, and I invite all of our communities and colleagues in this room today to continue strengthening our outreach and education, to increase representation in healthcare and research, and more importantly, to invest in health equity programs and policies so we can continue to help the patients that need us the most. Together, we can create a future where every Hispanic and Latino patient and every patient has access to high quality, culturally competent care. We can create a future where this is accessible for all. So let's continue to advocate, to show up. Los felicito por estar aquí el día de hoy, to educate, to collaborate, because our communities deserve nothing less. So muchísimas gracias. I appreciate you being here today. And I think I'm handing it over to Art. So Art Mote will help us wrap up. So Jeff, I don't know you.
Yeah, no, Art is a great guy. He's our final speaker. Art is our final speaker. Are any of you guys from Casa Aris? I see a few folks. He is also lives in Columbia Heights with me, so he's also a neighbor if you came from Casa Aris. So just wanted to mention that. Let me add it over to Art.
Thank you. I'll keep it brief. Art Motha, Director of U.S. Federal Affairs and Policy with AstraZeneca. I think I'm the last thing between us and lunch. My stomach is growling too, so I'm excited for that. But I wanted to share some of the science that we are following at AstraZeneca. Do we have any slides that we can pull up really quick? Just so that folks can get a visual as I speak here. But at AstraZeneca, we're transforming the future of healthcare by unlocking the power of what science can do. We follow the science. Sometimes the science doesn't go where many of us want it to go, but we want it to help a large number of patients. So we want to make sure that we have a healthy people, a healthy society, and a healthy planet. So we also care about the environment, the air that we breathe as well. Next slide, just to give you a peek into some of the work that we're doing in our various therapy areas across 3 different sectors. So oncology, biopharmaceuticals, and rare disease. So Many of us may take some of these medicines or know someone that does, but when it comes to oncology, it's really difficult as a pharmaceutical to say this, but we want to make sure that cancer is no longer a leading cause of death in our society. We want to transform and redefine what cancer care means, hoping to stop progression and maybe one day reverse it. In the oncology space, we are able to deliver our medicine through different forms, whether it's a small molecule, a daily oral pill, sometimes it's an injection or an infusion. So different ways to help people absorb medicine. We've been doing studies on how to do that. In the biopharmaceutical space, a lot of it is cardiovascular. We think about heart failure, hypertension, making sure that we have the right medicine at the right time. Many of us have experienced medicine that just doesn't seem to work, so we have to try a different medicine to see if that works. And then it's a long process. So we're trying to bring that down and follow the science. Renal, our kidneys, chronic kidney disease has been a factor that is very prominent in the Latino community. And metabolic health too. Not quite yet, but right now GLP-1s are the latest phase. We don't make that yet. We're in the clinical study phase and we're seeing good results. So hopefully soon we'll have a small daily pill that you can take instead of the injections out there on the market. I've been trying to join these clinical trials, but they won't let me. So maybe I'll wait till the GLP-1s are on the market for us to enjoy those benefits from. Respiratory and immunology has been a major factor for us, especially Latino seniors. We want to help seniors live longer lives with our medicines, especially in the vaccine space. And I mentioned, using that different ways of delivering medicine. We have a vaccine for the flu that is actually a nasal spray. So for folks that don't like needles, you can still keep up to date with your vaccines through a nasal spray. Sometimes we go back to our products and follow the science to see how we can best help deliver the medicine. Sometimes we transition from a capsule to a tablet to help your body absorb the medicine better. We had a capsule that released the medicine too soon, so patients' bodies weren't able to fully absorb the medicine. So we're studying that. Not to dive too deep, but also rare disease has been an issue where we're focusing more into as we learn more of different diseases out there that don't have a cure, let alone a treatment. We're working hard to make sure that we can help those patients. On the next slide is our vision to transform care. You've heard from some of the other speakers today on some of the work that they're doing, but for us at AstraZeneca, we are partnering across the world and across the country with different healthcare systems to make sure that we can, again, work together to reduce the progression of disease, a lot of the chronic diseases that we know we have medicine for out there, and of course, deliver healthcare. We keep pushing to get screened earlier and earlier. Many Latinos, whether it's us, our parents, our grandparents, or many of you in the room may not want to go see a doctor because we're stubborn and don't want the doctor to find something wrong with us. But that's the whole point of going to the doctor. If there is something wrong with our bodies, let's get it checked out and treated sooner rather than later. Making sure that our doctors follow proper guidelines that help with patients across the board. Building resilient healthcare systems and using technology nowadays instead of having to waste half a day traveling to see the doctor or traveling to get our prescription. Hopping on a video device or iPad to see or talk to someone on the phone that can help you maintain your healthcare. Just an example of some of the work that we're doing, and again, making sure that we have medicine for today and that we're doing the work to discover tomorrow's medicine and tomorrow's cures. So I'll stop there. Thank you all so much.
Thank you guys. So we're going to put a QR code on the screen there. If you are not a member of NHCOA's individual membership program, you could find information and join a growing movement of individuals dedicated to improving the lives of older adults, their families, and caregivers. So you can just scan that and you'll get all the information. You can also follow on social media, National Hispanic Council on Aging. They have all the social media sites at NHCOA for more information about upcoming events, and we'll be releasing the report and talking to member offices and also posting more about this event on social media. So follow us there and hope everyone has a great holiday. And let's give Dr. Cruz and the staff at the National Hispanic Council of Aging a final round of applause for all their work.
Thank you.
All right.
Okay, yeah. But anyway, Kelly, my head they have oh, that was the best one.
I mean, I remember we got contacted when these guys were.
Yeah, we did. It's okay, good. So yeah, it's not like we're ready for that. Stay out of it, but yeah, don't
Ron, I'm so sorry. Sorry, I have to run. Thank you.
Yeah, I was freezing.
Thank you.
Hey. So you took photos last time. I didn't get any photos. Where are they photos? Yeah.
I don't actually post anything myself, so I basically provide the photos to them.
Okay. Oh. Okay.
But I will. There we go. All right.
All right, good stuff.
Good. Thank you, sir. Yeah.
Let's